Hello, you've received this video because you've been referred to the ME CFS service and have your initial consultation very soon. You may be feeling quite apprehensive about this, what it involves and entails, and be quite confused about things you've read online or on social media about the condition. ME CFS is certainly very complex, both in terms of defining what it is and how it is diagnosed. But in this video, we hope to provide you with some useful information about the condition and outline what to expect at your initial consultation, what our service offers when a diagnosis of ME CFS is confirmed or not, as the case may be. As there is a lot of information in this video, you may find it helpful to pause it occasionally or watch in more than one sitting. So, what is ME CFS? In full, myalgic encephalomyelitis or chronic fatigue syndrome. We commonly merge these names together and use ME CFS to broadly describe the condition, and we'll use this terminology throughout. The World Health Organization classifies it as a disease of the central nervous system. In England, the Department of Health defines it as a neurological condition of unknown origin, and it's widely accepted in the medical world as a complex condition with no single clear-cut cause. There seems to be a wide variation in how people present with ME CFS, both in terms of symptoms and the severity of the condition. Some people may still be working, whilst others may be housebound or even bedbound at times. Reported cases over the years point towards the most common peri-onset or predisposing factors being viral infections or stressful life events. More recently, there's emerging scientific evidence pointing towards dysregulation of the central nervous system, and that central brain mechanisms are important in the production of mental and physical fatigue. In the respect of PVFS, this stands for post-viral fatigue syndrome, a sidestep from ME CFS. This is defined where we can trace the onset of illness back to a clear viral infection, and it's often appropriate as a diagnosis when an extended period of ill health and debilitating fatigue follows an acute infection, and a diagnosis of ME CFS is not yet appropriate. It's certainly a complex condition. Clinically, ME CFS is a complex, diverse, multifactorial condition, which does not have a disease-specific biomarker, which basically means that a blood test or scan does not tell us if you have it or not. Despite ongoing research, there is still no single satisfactory cause or rationale why some people develop the condition over others who may have had similar background factors in their lives. The consensus that's emerged from the broad range of ME CFS organisations, medical researchers, and the National Institute for Clinical Excellence, known as NICE, is that ME CFS may be a three-stage illness involving predisposing, precipitating, and perpetuating factors. Predisposing factors are contributing factors, which might include significant life events, previous illnesses, or a genetic predisposition, and there actually may be several layers of predisposing factors for people. Precipitating factors are more acute triggers, which might include a recent viral infection or a prolonged period of heightened stress, prolonged overexertion, or a traumatic event such as bereavement. Perpetuating factors are continuing to maintain the fatigue, and these might include persistent biological and emotional stressors, other health concerns or conditions, and environmental factors. NICE estimates that the prevalence of ME CFS in the UK is around 0.2 to 0.4 of the adult population, so somewhere in the region of 250,000 people. For some reason, more women seem to develop it than men in the ratio of about 3 to 1. The most common age of onset is between the early 20s and mid-40s, and whilst there are many people who develop it older and younger, it's certainly less common in very young children or as a new onset in older adults, where there is more chance of other conditions associated with ageing starting to develop. It appears that ME/CFS affects people from all social groups and is described across the globe by people from all ethnic backgrounds. But it's also been shown in research that there is a higher rate of prevalence in first-degree relatives. So, your route to getting to see the specialist service has presumably followed this path. Your GP referred you as he or she suspected you had the symptoms characteristic of ME/CFS. They took blood tests to rule out anything obvious and hopefully considered and ruled out other possible reasons for you to have developed fatigue. For a diagnosis of ME/CFS to be considered, you must have all 4 of these symptoms. Debilitating fatigue that is made worse by activity, cognitive or physical. Post-exertional malaise, PEM, or symptom exacerbation. This is known as the cardinal symptom of ME/CFS, described as a worsening of symptoms following even minor physical or mental exertion, with symptoms typically worsening 12 to 48 hours after activity and lasting for days or even weeks. Unrefreshing sleep or sleep disturbance, perhaps waking as tired as you went to bed, waking in the night for no reason, feeling tired but wired when you go to bed. And cognitive dysfunction, brain fog, poor memory and concentration, word finding difficulty, amongst others. As well as the 4 main symptoms, we expect people to describe having several of the following as new symptoms as well. Orthostatic intolerance and autonomic dysfunction. This includes dizziness, palpitations, fainting and nausea on standing or sitting up from being in a reclined position. Body temperature regulation problems, feeling hot when everyone else is cold or vice versa, feeling like your body's internal thermostat isn't working. Neuromuscular symptoms, such as occasional twitching or jerking of the body. Flu-like symptoms, perhaps a frequent sore throat, tender glands, nausea, chills, and body aches. New intolerances, perhaps to alcohol or certain foods or chemicals in everyday products. Heightened sensory sensitivities. And pain, usually in the form of new headaches, eye pain, widespread aches and pains, but not with swelling or inflammation. It's important to be sure that before considering a diagnosis of ME/CFS, that other physical and psychiatric conditions that may cause fatigue are excluded. It's usually the case that with ME/CFS, the symptoms are definitive and of new onset, not lifelong. And the fatigue causes substantial impairment, having a significant impact on occupational, social and personal activities, and is not alleviated by rest alone. Many people assume all chronic fatigue and tiredness is the condition ME/CFS. But being tired all the time is a common complaint to GPs, as many as 1 in 5 adults. And as you may now realise, this alone does not necessarily meet the criteria for ME/CFS. For people with chronic fatigue who do not have all the other symptoms of ME/CFS or another condition that causes fatigue, it's suggested as idiopathic chronic fatigue. For these individuals, their fatigue may improve by reducing physical and mental activity and improving sleep, which is not the case for people with ME/CFS. Fatigue is a common symptom of many illnesses and conditions, such as the following: sleep disorders, vitamin deficiencies, chronic pain syndrome, such as fibromyalgia, autoimmune conditions, mental illness, cardiovascular disease, obesity, endocrine disorders, such as an underactive thyroid, neurological disorders, and the menopause. So we're keen that in considering a diagnosis that nothing else is being missed. Many of these conditions have a medical management option, which could be of benefit. Essentially, we want to ensure as best we can that you are in the right service that can help you most. Sometimes people have had another medical condition for several years, and it's sometimes considered stable when the fatigue starts, and that there's an overlap in these conditions with ME/CFS. This adds a layer of complexity to the assessment and diagnostic process. So each case needs careful consideration, and we spend time with you to understand your specific situation. You will probably be aware that long COVID shares many symptoms with ME/CFS. For some of you, this may even have been the trigger for your symptoms and fatigue and the reason you've been referred to the team. Post-viral fatigue is one of the most common symptoms reported after COVID. However, many people with long COVID continue to experience respiratory or cardiac problems, and this is not consistent with ME/CFS. So these individuals require intervention and investigation with the specific long COVID, post-COVID service. Where there are no other red flag type symptoms and a person has post-viral fatigue after COVID, they may end up meeting the criteria for a diagnosis of post-viral fatigue syndrome, as mentioned earlier. And then these people may subsequently be referred to the ME/CFS service. So, at your appointment, your consultation will be with one of the specialist clinicians in the team, and using the information from your pre-clinic questionnaire, along with your medical history, we will explore and discuss with you the factors which have impacted and influenced the onset of your chronic fatigue and presenting symptoms. We will go through the ME/CFS symptom criteria, and we'll take time to understand the physical and emotional challenges you might be struggling with and how your fatigue affects your current lifestyle and routines. We hope that by being thorough and taking all this information into account, we might formulate a clinical opinion. This may result in us confirming ME/CFS or PVFS. But in a proportion of cases where there are complexities in terms of other health issues or investigations and comorbidities, we may decide it is prudent to initially suggest a working diagnosis of ME/CFS or that you have complex multifactorial fatigue, often the case when someone has another condition and it's not possible to separate out if the fatigue or symptoms can be fully excluded from that condition. So what next? After your consultation, the specialist clinician will write a detailed report which will be sent to you and your GP. This may include any recommendations to your GP or signposting you if these were things discussed in your appointment. This might include something like a referral to the sleep clinic or signposting you to an online support group. It's important to mention that at present there is no medical management or medication that's recommended or available on the NHS for people with ME/CFS. We are a therapy-led service, and your GP remains responsible for any prescribing of medication. There are some medication guidelines provided by NICE for the management of symptoms associated with ME/CFS, such as pain and sleep, but not for fatigue itself. Your GP will be provided with a booklet for them to refer to with further details. So, what next in terms of therapy? If it's appropriate, we'll discuss with you accessing further support with the ME/CFS therapy team. This includes a variety of helpful interventions to support you understanding and managing your condition. We send videos to watch, information booklets on different topics, and offer one-to-one therapy sessions with the aim of equipping you with tools and strategies that help you live as best you can with your health condition. And further information about this will be provided after your consultation. So, thank you for watching and listening to this video. We hope you found it helpful and that you feel more informed as to what to expect when we meet you. Until then, take care and goodbye.